his advanced fellowship training in neuropsychology and gerontology in the Geriatric Research Education and Clinical Center at the VA Puget Sound Health Care System in Seattle and the American Lake, Washington. It's a lot. He has a lot of experience, and so he's going to be sharing with us today neuropsychology of Parkinson's. So I'm Anissa with PMD Alliance. I didn't mention that earlier, but I'm going to pass this off to Dr. Logalbo to get us started. As you guys have questions, because we do have a fairly large audience today, if you would be willing to chat your questions, I will make sure that we get to those towards the end of the presentation today. Well, welcome, Dr. Logalbo.
Thank you, Anissa. I appreciate that introduction and also the opportunity to be able to speak with everyone today on a topic that I think is very important. It's a very interesting topic to me, but also something that I hope will be informative to you guys and maybe spark some questions or some further dialogue. Let me share my screen here, and okay, hopefully that's full size there and everything. Like Anissa mentioned, I was previously at Advent Health, or Florida Hospital it was called at the time, in Orlando, but I'm actually now a professor at Florida Tech, which is in Melbourne. And for those of you who may not know where Melbourne is, I'm not talking about Australia, unfortunately, but it's on the east coast of Florida, just south of Cocoa Beach and the Space Coast, as it's known out here. But in my capacity at Florida Tech, in addition to teaching classes and supervising graduate students and things like this, I'm also the director of neuropsychology at a memory disorder clinic here in Melbourne. And we see probably mostly patients with Alzheimer's disease, but also a fair number of folks who have Parkinson's disease, and unfortunately even some who have both at the same time. So this is an area that I'm still very passionate about, still active with, and also doing a little bit of research more on the cognitive side of things, which we'll get through a little bit later on today.
Dr. Logalbo, can I interrupt you real quick? I'm sorry.
Sure.
There's some wind sound coming from your mic. I don't know.
Okay. Hold on one moment. Let me see if this helps.
Okay.
Does that seem better?
Yes.
Maybe.
Did you turn off that fan?
Yes. We'll see how hot it gets in here now.
Awesome. Thank you so very much.
Sure, no problem. So I thought this might be a good question to start with. What is a neuropsychologist? And perhaps some of you have seen a neuropsychologist before or have heard that term. But I know many folks probably have not. And even when folks were referred to see me, they may not have known exactly what they were getting into when they made the appointment. But basically, a neuropsychologist is someone who is a clinical psychologist by training. So we do not have a medical degree. It's a psychology degree. But we specialize in working with folks that have different types of neurological conditions, and in particular, how the effect on the brain neurologically can translate into changes in our behavior as human beings. And one of the main areas that we test and evaluate as neuropsychologists has to do with our thinking abilities, our memory, our concentration and attention skills, language, problem solving, things like this that we'll get into here a little bit more in a minute. But the other side, we are still psychologists after all. The other side of that is still being interested in how these changes in the brain can also affect our mood and our emotions. And there can be a range of emotional reactions that people may have when there are changes going on inside of the brain. It could be depression, it could be anxiety, it could be irritability and getting upset very easily, having a shorter fuse than normal. And to some degree, all of these things are common when there are changes going on in the brain. Some things that you may know, but just to kind of make sure we're on the same page here, in Parkinson's disease, the main neurological feature that often gets discussed or pointed out are these changes in the substantia nigra. And this gives you an idea of where that is inside of our head. It's kind of almost right in the center of our head. And what this image shows is that there is a diminishment in the substantia nigra of those dark or pigmented areas. And what these are primarily are dopaminergic pathways, which we'll talk about dopamine here in a second too. Another thing that happens in Parkinson's disease, and actually a lot of other degenerative diseases, is that there's a loss of neurons in the brain. And this just gives you sort of a visual image of what normal brain tissue would look like versus someone with Parkinson's disease. In certain areas of their brain, at least, there may be this reduction in the number of neurons in the brain tissue itself, which can also contribute to some of those cognitive and motor types of symptoms. Perhaps some of you have heard of this thing, Lewy body, which, sometimes I like to say that in medicine, they're not that creative when coming up with names. They often just get named after the person that found them, which is the case here. Frederick Lewy was this guy's name who discovered these things. And Alzheimer's seems like it gets a little more attention in terms of the underlying pathology of the disease. But Lewy bodies are more characteristic of Parkinson's and Parkinson-related types of conditions. It's not as common in someone that has Alzheimer's, but conceptually it's kind of similar in the sense that it's an abnormal accumulation of protein. We all have protein in our brain, but when it aggregates and accumulates to an abnormal degree, sometimes it can cause problems. And the protein that is implicated in these Lewy bodies is called alpha-synuclein. The proteins that are implicated in Alzheimer's disease are amyloid and tau. So maybe you've heard of those. Whole bunch of different kind of proteins. There's not going to be a quiz at the end here, so you don't have to memorize all of those. But just to know that it is a similar sort of process as Alzheimer's, in that there's this protein that accumulates, but it's a different protein. And they form these Lewy bodies. There's another condition called Lewy body dementia, which some of you may have heard. Sometimes that gets confused with Parkinson's. They're very similar. And in my mind, the way to differentiate them really is based off of which symptoms started first, physical or more cognitive types of symptoms, which ones started first. But even then, sometimes it's difficult to differentiate. So I mentioned dopamine, and I imagine that many of you have seen or heard something kind of like this before. This neuron up here at the top left shows what a normally functioning neuron might look like in terms of the amount of dopamine that's released and how it binds to the next neuron in that pathway in our brain. Whereas a Parkinson's neuron is not releasing anywhere near as much dopamine as it normally might. And so it's not able to pass that message along to the next neuron. And here's just some examples of the physical symptoms that this can cause: tremors, rigidity, and a slowness in our movement. And this image, the right side of this image with the brain here points out, again, some of those integral sort of areas, the substantia nigra, again, being sort of right in the center of our head, but this also shows this pathway in this red arrow, the pathway between the substantia nigra and working up towards the frontal lobe. That pathway being disrupted causes a lot of the motor symptoms that are associated with Parkinson's. And on this image, that's illustrated in this green line, which again, I think, and you guys might have a different perspective on this. If you do, I'd be curious about that. But from what I hear, both in the clinic and out in the world, it seems like the focus often with Parkinson's disease is on the physical symptoms, which of course, often makes sense. But what this slide here is trying to show is that this green pathway here, these green arrows, that's not the only place that dopamine exists in the brain. It's an important one, and it's definitely involved with those motor symptoms. But this blue series of arrows that goes kind of throughout all of the brain, just about, as well as this red pathway here, these are also dopaminergic pathways. And so when there's a substantial reduction in dopamine production in the brain, it's not usually just in this one little green area. It can actually go throughout other areas of the brain. And this is where we might start to see other symptoms besides just the motor symptoms. And these blue and red boxes over here on the right give you an example of what some of those are. Problems with our thinking, like memory and attention, problems with maybe behavior and emotional functioning, and things like this that can also be symptoms. Maybe they're not the most talked about symptoms sometimes, but also can be symptoms related to that neurodegenerative process that we see in Parkinson's, the brain of people with Parkinson's disease at times. So kind of along those lines, I found this image that I kind of like to show. I say here the possible progression. There's no way of determining, the future precisely for every individual. However, we do know that Parkinson's disease is a degenerative disease. So as time goes on, it's likely to get worse in some fashion. Up at the top, what this is trying to illustrate is that the problem areas, let's say, which are signified by these sort of pinkish areas, as well as these kind of, brownish green kind of dots that show up later on. For the most part, it's kind of isolated to that one area of the brain, kind of in the center there, where this spot is that goes from orange, brown, and then black, that kind of center area. A couple little spots show up here and there, and as that becomes more common for it to kind of disperse like that, the likelihood of developing dementia or some kind of cognitive problem is increased. Unfortunately, there's a subset of people who have Parkinson's disease that do develop dementia. I was just looking this up today to try to find some updated statistics. The most updated number I could find was it's approximately 30%. It's based off of whatever sample they were, asking at that particular time in that study. I've seen it vary a little bit from there, but it's certainly less than half. Somewhere around 30% of people with Parkinson's disease are likely to develop dementia. But I would say an even greater percentage than that, at some point, will have some cognitive changes. It may not be so severe that we would call it dementia. They might be relatively mild, but that is something that can happen. And I'll talk about what some of those changes are. But this is part of the reason why those changes take place. And that is that this disease, it kind of starts in that substantia nigra, that center area of the brain. But for some people, it has a tendency to spread out into other areas of the brain a little bit more than others. And when that happens, that can cause problems, obviously, with other areas. all of our brain has different responsibilities. Each part is kind of unique in terms of what it's responsible for. And so the more areas that are affected, the more different kinds of problems people sometimes can have. So what are some of these cognitive, and I guess what sometimes this term gets used, neuropsychiatric symptoms or features of Parkinson's disease? More specifically, what are the more common types of problems? Well, I say forgetfulness because I think that in most people's day-to-day experience, they might notice this. And gee, almost anybody that came in to see me for an evaluation was complaining about forgetfulness, whether it was walking into a room and I forget what I went there to find, or I can't find my keys, I misplaced them somewhere, or something maybe a bit more, problematic, like forgetting to pay bills. And so now I'm getting late fees and having my electricity shut off or something like that. However, generally speaking, the degree of memory problems that we usually see among folks who have Parkinson's is nowhere near the type of memory problems that we usually see in folks with Alzheimer's disease. Folks with Alzheimer's, their main problem is a memory problem, and usually it can be rather significant. So memory isn't the only issue here with Parkinson's, and actually it's not one of the main things. Many people experience difficulties concentrating or paying attention. They might have some slowness in their thinking speed. It can take longer for them to get things done, and that might sound a little obvious when you're talking about a physical activity, but even a mental activity, even something that's not very physically demanding, sometimes can take longer to accomplish. It can be harder to figure things out, a new problem that I'm faced with that I haven't quite encountered before and I have to think it through. That can be a little more challenging. Obviously being more tired more easily, getting frustrated more easily, and sometimes not having as much initiative or energy or pep to kind of get up and get started on a project or an activity. So I wanted to spend a little time talking about this concept in particular, and maybe this is something that can relate to some or many of you. When something takes me longer than it used to, when it's much slower to get it done, I think a common emotional reaction we would have to that is being frustrated. We're going to be upset with ourselves or with the situation that we're not able to do it as quickly as we used to. And I sometimes also think of this balance that exists between speed and accuracy. Sometimes we might try to rush through something anyway, but it can backfire in the sense that we're more likely to make mistakes and it's not going to be as accurate. So sometimes it's important to slow down and take our time. And that can be frustrating because it might take us a lot longer. But if that is the way to ensure that we're still accurate, sometimes that's a payoff. Of course, it depends on what the task is and what you're trying to accomplish. Maybe some of you have encountered this, and a lot of patients that I saw, this was something that frustrated them beyond belief. Even though it might be easier for someone else to do it, that doesn't always mean they want someone else to do it. So like tying my shoes. Okay, sometimes it might be easier for someone else to do it and quicker, but I might also appreciate the satisfaction of doing it myself, even though it takes longer. And that's one of those things that's kind of hard to balance sometimes. And it gets to that last concept there, where a lot of folks feel a loss of independence, a loss of ability. That can be just like a grief reaction. You're losing something that you used to have, and it's not an easy adjustment sometimes to accept that that's how things are, or to find new ways of doing some of those activities. So So you're still able to get that sense of accomplishment, but maybe you have to go about it differently. So that's getting a little more obviously into the emotional side of things, but this is how sometimes the cognitive and the emotional can overlap. You know, something's taking us longer because of a slowness in our thinking, but the result of that is emotional frustration, and taps into this adjustment type of issue that can be very difficult to get used to.
Can I ask you a quick question?
Yeah, sure.
I asked about working memory. So is that something you're getting ready to cover, or can you add to that?
Yes, it's kind of related to this actually, what I was just going to discuss, but I don't know that I would have mentioned that specifically. So I'll include it in this discussion here. Executive functioning is a term that sometimes gets used, but I think can be a little confusing to understand what it is exactly. And part of the reason is that it means a lot of things. And these are some of those things that it can mean. And because it can mean all of these different things, sometimes it feels like, well, it just kind of means everything. And it gets a little confusing that way. But an aspect of executive functioning, some people would say, is working memory. So working memory, when I think of working memory, what I'm talking about is something like this. If Anissa just now reads me a phone number, and then I have to go over here to my phone and dial that after she read it to me, the amount of time that passes between her reading me that number and me dialing it, that's the only amount of time I need to remember that information. Later on today or tomorrow, I'll probably forget it, but that's probably okay. I don't need to remember it tomorrow. I only needed it in that moment. Well, my working memory allowed me to remember that number so that I could, after she said it, dial it into my phone. That's very different than something like, I guess, let's say long-term memory, my ability to remember something from when I was a child, or even short-term memory, if what you mean by short-term memory is remembering what I had for lunch yesterday, remembering the conversation I had with a friend over the weekend. You know, those are things that I would not classify as working memory. Working memory is more my ability to actively think about or manipulate information in my mind. I don't have to remember it later. It doesn't have to go into my storage bank, but I need to do something with it in the moment. Another example that sometimes people use for working memory is doing a math problem in your mind. You know, you kind of have to juggle those numbers and make that addition or subtraction or multiplication. Later on that day, you may or may not remember that information, but your ability to manipulate those numbers and do it in your head without using a calculator and writing it down, that's another working memory type of task. Now, some other things that fall into this executive functioning umbrella are things like planning, organizing, problem solving, thinking through a solution to a problem, maybe our ability to make a decision in a unique situation, our judgment. These are all things that can be a little difficult to measure, honestly, but these are some of the higher level thought processes that we are pretty unique as humans in having. You know, other species may have the ability to concentrate or remember things, but these higher level thought processes are thought to be unique to us for the most part. And so these things are often more complex and come into play when someone is doing something that's harder, more challenging, maybe in a work environment, maybe a student going to school and having to learn and remember a bunch of new information. So executive functioning, like I said, it's kind of a confusing term. It can mean a lot of things, but these are some examples of what those are. And occasionally, if someone's having trouble with these executive functions, there isn't always a real easy way around it. For example, if someone's having trouble making decisions and their judgment is a little bit off, they may not know that. They may not be aware of it. And so even if they do something to try to account for that, it doesn't always work out so well, which is why I put there on the bottom, often a solution for some of these kind of problems is to ask other people for help. That's not an easy thing to do sometimes from the standpoint of pride, but sometimes that is the best way. Because otherwise there can be situations where people really get themselves into a bad situation. And we'll talk maybe a little bit about what some of those could be. So what is a neuropsychological evaluation? Again, maybe some of you guys have been through this before, but basically it's a bunch of paper and pencil and question and answer kinds of tests. We do not do any medical procedures. We don't take your blood or do any scans. These are all administered usually by a person, although some of them are computerized now. And we test learning and memory. We'll read things to you or show you pictures we want you to remember. We might have a stopwatch and ask you to do things as fast as you can. We measure some of those problem-solving skills, those executive function skills that I mentioned. Language abilities like coming up with words, visual, spatial kinds of skills, which looks like what this person is doing in the photo. And also ask about mood and behavior or personality changes, because these are things that can also, as I mentioned before, they can also be affected when there are changes going on in the brain. Now, after going through this evaluation, one might ask, okay, well, if I have problems in those areas, what do I do? And it kind of depends on what the problems are. But in general, one of my approaches always is to try to develop strategies, try to develop things to compensate for some of the difficulties that I might be having. And some of these aren't rocket science, and actually some of these might be things that many of you do already. But you might be surprised at how many people don't do some of these things. And if they did, it could really help a lot. So writing things down and taking notes, and this can work, but it can also not work. And I'll give you a personal example. I used to love these Post-it notes that are stamped on this guy's head here. And I would write things on them and stick them in places, but then I would forget where I put them. And I know that I wrote something down, but I couldn't remember where I wrote it. So having a strategy like writing things down only works if you keep that stuff organized and you know where to find it. I learned the hard way, and now I do a better job with that. Some people use a day planner, a calendar. It can be, the old-fashioned version on paper or the new electronic version on your phone or computer. Keeping a routine schedule, having a pattern, a habit, doing things kind of the same time or the same way can help. Using checklists, especially if there's a particular sequence of steps that needs to be taken. Setting alarms as reminders. I do this all the time. I need something that beeps at me. I found out though too, another learn by making a mistake. If you don't put on there what the alarm is for, you might forget. So your alarm is going off, but you don't remember why you set the alarm. So, coming up with a lot of strategies to try to make sure that the strategies you're using actually work. That's another important concept here. We talked before about things taking more time. And if I know that that's the case, then I might need to plan for more time to get things done. And this is always hard, I think. We tend not to be the greatest judge of estimating how much time something might take for us to do. But if you know that that's true for you, then I would just always plan on assuming it's going to take longer than I expect. And sometimes that can work so that you're not feeling a lot of time pressure and feeling rushed at the end to get something done. Slowing down, again, kind of a related idea. You're less likely to make errors. I think that's true for all of us, really, if we slow down and take our time. Doing one thing at a time. A lot of folks pride themselves on being great at multitasking. But I kind of think to a degree that people who multitask, often what they're actually doing is switching back and forth between tasks. They're not literally doing 2-3 things at the exact same time simultaneously. And that little bit of shift going back and forth between things, sometimes it's actually better to just do one thing at a time than kind of shifting between things. So I don't perceive that as a negative, doing one thing at a time. Reducing distractions in our environment, like fans that may be blowing into your microphone, perhaps, or maybe there's someone out there mowing the lawn. It might be harder for me to concentrate, so I might need to put that task aside until it quiets down. And again, asking other people for advice. This one, not everybody, I'll admit, even myself, sometimes I'm not the best at that, but part of this process, I think, is kind of learning our own boundaries, and when we need to ask other people for some assistance. I found this quote, which I think I've shared before with some folks, but and really, I think to a degree, this can apply to a number of things, not just Parkinson's, but it says, the worst day of this disease was the day I was diagnosed. The best day was when I understood I could do something about it. It gave me back a sense of control in my life and some power. And again, I can tell you, just, I don't know if this relates to some of you guys, but a number of folks that I saw and still see, this is part of what they struggle with, is feeling this loss of control, like this condition is kind of taken over their body, and they don't have a lot of control, certainly not as much control over themselves as they used to, and how frustrating that can be. And certainly anyone who feels like they're stuck and there's nothing that they can do about whatever it is, that's not a pleasant feeling to have for anyone. And I'm not suggesting here that there's a way to 100% turn that around, but to the degree that you can find some strategies and techniques and things to try to get that sense of control back, I think for most of us, that's a good feeling, to feel like, okay, I don't have control over everything. I think over the past several months, we all have kind of learned that we don't have control over a lot of things anymore. But if you can start to gain a little bit of that control back, that does a lot actually for our mood and our self-esteem. So what about mood? There's a number of terms, I guess, that kind of get thrown around when we're talking about mood changes. Depression certainly is one. However, some people that I've talked to say, well, I don't really feel depressed, or at least they wouldn't use that particular word for it. Sometimes maybe they feel sad or frustrated or angry that this is happening, and frustrated that they can't, seems like they can't do much about it. Like I mentioned before, maybe getting more irritable and even lashing out, and that might be very uncharacteristic of you, but now you're doing it a little bit more. Sometimes these things, even though we may not really think of them or call them depression, they may be related to a depressive type of condition that's going on. And unfortunately, and some of you may be familiar with this, some of these mood disorders like depression, we're finding that they actually have a neurological basis. And there's in terms of how our neurotransmitters function, sometimes that contributes to why anybody might get depression. And so when you have a process going on inside of the brain that's causing some of the changes that Parkinson's disease can cause, and disruption of dopamine, one of the main neurotransmitters in the brain, there can also be a neurological basis to having mood and personality and emotional changes too. So yeah, someone on the outside might look at it and say, oh, well, it's understandable that you're depressed because you've been diagnosed with Parkinson's, and that's a depressing thing to have. Okay, well, maybe that's true for some people, but for many people with Parkinson's disease, they might have depression anyway because of the changes in their brain, not because they're having a reaction to being diagnosed, but because there's a neurochemical change in the brain going on that predisposes some people to feel sad, to have more anger outbursts, to be more irritable than they used to behave in ways that they didn't used to behave, to maybe feel more anxious than they used to in certain situations, and feel more stressed and overwhelmed by things in life. So I think, or I hope to some degree that knowing this is, this might sound strange, but in a way a little comforting. I've found in describing some of this to patients at times that they appreciate knowing or understanding at least that part of these mood and emotional changes that they're experiencing are because of this thing going on in the brain. It's not because you're choosing to be sad. It's not because of anything you're doing wrong or intentional. It's because of some of these neurological and neurochemical changes that can cause or contribute to some of these mood and emotional changes. And I like this little cartoon. It says, this man is going to see a therapist, and the therapist says, you worry too much. It doesn't do you any good. And he says, it does for me. 95% of the things I worry about never happen, which probably is true for a lot of us. I guess in his mind, he thinks that means memory is, or worrying about things is working. It's preventing them from happening. So I wanted to talk a little bit about some other mood or emotional kinds of changes that don't quite maybe fit into some of those categories that were on the previous slide of depression, anxiety, and things like that. These are things that can happen actually in a number of conditions, a number of neurological conditions, but certainly can happen in Parkinson's disease too. Having less interest or enjoyment in activities, something that I really, really used to enjoy, and now I could almost care less. It doesn't really sound that fun or enjoyable. Being less social, being less interactive with people, less desire to do so, having less emotional reactivity, and I think maybe a lot of you have seen something like this picture, this cartoon here that kind of shows the different facial expressions of folks who have Parkinson's, and you can see the joke there. They're all exactly the same, except for maybe the over-medicated one. And so, again, this is part of the neurological condition. Some people might misinterpret this as being depression, because often people who are depressed don't show a lot of emotion. They might be very flat. And so the assumption here might be, oh, well, if you're not showing emotion, you must be depressed. And that's not always the case. As I'm sure you guys know, part of the movement problem in Parkinson's can also affect the muscle of our face and our facial expressions. And so it can be pretty common actually for someone to have the emotion inside. They might feel happy, they might feel sad, but someone, especially who doesn't know them, just looking at them may not be able to tell. And some other changes in personality, we'll talk about that a little more. Sleep, appetite, some of our other kind of regular daily functions can happen too. I use this image to kind of illustrate something that can be rather scary for a number of folks. Not everybody experiences these things, but just to cover the gamut of what can happen potentially. Some people with Parkinson's or other Lewy body related conditions can have pretty vivid visual hallucinations. And often they're really not scary, believe it or not. The person who experiences them doesn't always perceive it as threatening. In fact, one of my sort of favorite stories about this, I had a Parkinson's patient one time who he lived with his wife and no one else lived in the house. And he had gone down for a nap and he woke up and he came out into the dining room. And he saw all of these people here and they were so well dressed and it looked like they were here for a dinner party and they were just chatting amongst themselves. And he walked into the kitchen and his wife was there making a cup of coffee, but she wasn't preparing any food. And he said to her, "Well, what are you doing?" And she said, "What do you mean?" And he said, "Well, we have all of these people here for dinner and you haven't prepared anything." And she said, "All of these people, what are you talking about?" And they went out into the dining room and of course it was empty. There was nobody there. And he didn't realize it at the time, but also really wasn't threatened by it. It wasn't particularly scary. And that's often how these are described. But if nothing else, sometimes to the family members, it can be a bit unsettling to have your loved one, someone you care about, tell you that they're seeing something that's not there. You know, that sounds really odd, really unusual. Sometimes this can be related to the disease process itself, and sometimes it can also be related to a medication. In fact, some of the medications that are used for Parkinson's, the dopamine medications, if you've had a change in the dose of those medications recently and then start experiencing some of these hallucinations, that probably is something to talk to your doctor about. But it's just another thing that you need to be aware of. It may never happen to many folks with Parkinson's, but it's something to be aware that it can happen. And this is another one of those things. Again, some of you may have heard of this. REM, which stands for rapid eye movement, REM, sleep behavior disorder. Most of us, when we're sleeping, our body basically paralyzes us, so we're not able to move around that much. However, people who have this, which is fairly common in people that have Parkinson's, seem to kind of act out their dreams in sleep. And very often they're not the one who's too concerned about it or even notices it. It's the spouse because they get kicked or punched or attacked in the middle of the night. And so again, this is not something that everyone might have, but definitely something that can be disruptive, again, if nothing else, to the partner. And also can sometimes be disruptive of sleep in general, even though people may not wake up and kind of sleep the whole night through. The quality of sleep might not be as good, which can mean you're more tired during the day. And then the last sort of behavioral type of thing that I'll talk about here is this one. Sometimes people, again, with a lot of different neurological conditions, can have trouble with impulse control. And what do I mean by that? Well, in this example here, if you're familiar with this guy, Pierre, he just can't resist that sign. You know, there's a big, flashy, shiny red button right there, and he just can't resist what the sign is telling him, and he's got to go ahead and push it, even though it says clearly, do not push. And this is maybe a silly sort of example, but oftentimes people who have trouble with impulsive types of behaviors can get themselves into trouble. Sometimes it's financial, you know, buying a bunch of things, even duplicates of things that I already have or don't really need. For some people, it might be impulsive gambling or engaging in other sort of risky behaviors, whether it's of a sexual nature, perhaps, risky in some fashion, and not necessarily seeing in the moment, at least, that this is a problem or what the potential consequences of it could be. Again, this is not something that everyone will experience, but it's, as you can imagine, something that can at least cause a lot of disruption in a family, and at worst, maybe put someone at risk, either financially or in terms of their health. And again, part of the neurological component of this disease, our brain is not functioning quite on all cylinders. And so we're not able to control this as well as we used to, or as well as a lot of folks should be able to.
Dr. Logalbo,
Yes.
can that also include like just general fixation behavior, not specifically like impulsive gambling or hypersexuality or shopping, but like just fixated, and it can even like fixation on I have to watch this show so many times, or fixation on making sure that I've checked the doors and that they're locked. Is that a part of it as well?
Well, I suppose it could be, but it could also be something else. and if someone was telling me that this was the kind of experiences that they were having, or their family maybe was telling me that they seemed to be fixated on a TV show, or they seem to be doing these checking behaviors over and over. One thing that I would make sure that I clarified is this new? How much of a change is it from before? And when did it start in the sequence of things here? Some people have always been that way, or maybe to a degree they've always been that way, and now it's sort of amplified. And so that may or may not be a Parkinson's symptom, but could be exacerbated by those neurological changes, perhaps. Usually the time that those behavioral changes get brought to the attention of someone, which is kind of what I'm talking about, was going to talk about here, it's when they become overly problematic. And so, it could also be that if someone wants to watch this show 50 times, they may or may not discuss that with their doctor, because that may not really be that much of a problem. I mean, to some, it may take a lot of time and so on. And maybe it's a little annoying if I don't want to watch that show and he does. But it's usually the more extreme kinds of behaviors, I think, that get brought up and mentioned as being problematic. So I guess my point there is that I and others just may not hear about some of those more subtle, I'll call them subtle, they may not seem that way to the person, but subtle kinds of behaviors compared to some of the more extreme things that can happen when things go really in a negative direction. Does that make sense?
It does. It does. And I know you're getting ready to talk about what and when they should be approaching their physicians. And I can tell you that your content has brought up a lot of questions. Really good. It's springboarding a lot of great questions.
Great. Well, I think I have a few more slides. I'll try. I know maybe we don't have a whole lot of time, although I'm free to stay a few extra minutes if that's an acceptable thing to do. Just briefly, what I wanted to say here, and I kind of said it already, the answer to this question is going to vary depending on each of you. I would, on one side, suggest that if you're having any of these things, it's worth bringing up to your doctor. Whether they might do something about it or not is another question, but it's at least worth mentioning. But usually the ones that get mentioned are the ones that are concerning either for the person themselves or their family. And so if these things happen once in a while and they're not causing that much of a problem, that's one thing. But if they're happening frequently or they're very disruptive or causing a lot of tension in the family, it's definitely worth bringing it up. So some other strategies, and I'll kind of try to go through this again, because some of this is probably stuff you've heard or seen before, but doing things like this, learning and receiving education can be helpful to understand better what I'm going through and why. Sources of family and social support, which sometimes means attending support groups or having conversations with other people that are going through something similar. The things toward the end can be a little more kind of general and maybe dependent on the symptoms that someone's having as far as the physical symptoms in particular. But counseling, I will mention a number of patients that I had either with me or others would engage in counseling to try to help with that emotional adjustment process and kind of thinking through some of these different ways of doing things so I can still function as best as possible. I mentioned, I think before, the more scheduled and routine that we are, usually that works better for all of us in terms of keeping up with activities. I do a lot of breathing exercises and meditation myself and encourage a lot of folks that I work with to do those kinds of things. Nowadays, it's pretty easy to find that kind of stuff for free online. There's apps you can get on your phone, a lot of things available to try to help with engaging in some of those relaxation techniques. Maintaining a positive attitude, again, trying to see the silver lining or look at things in a different way. And sometimes, again, being more consistent with our sleep, pet therapy. Some people may have pets or have access to pets. That can be a source of enjoyment, as well as engaging in activities, even if it's something you've never done before, something that's stimulating, something that's creative, something that's different. Of course, there's physical exercise and activities that can be helpful for some of the motor symptoms, but I would say even exercise is helpful for our mental health and our cognitive health too. And I often encourage people and try to do this to some degree myself to engage in new things that you haven't done before. And even if you just do it once and you decide I didn't really like it that much, at least you gave it a shot. And this gentleman, you've probably seen things like this. This was a gentleman, I think from Indiana, who never was an artist, but decided to take up doing some artistic paintings. It's a gentleman with Parkinson's disease. That doesn't have to be your thing, but finding something new, something different, something that might be creative that you can engage in to stimulate a different part of your mind. Just briefly, I'll say, again, there's some other areas, more complex levels of functioning that sometimes people can have trouble with that are necessary for our daily lives. Remembering which medications to take and when, keeping up with our bills, driving. And these are things aren't going to cause a problem for everybody. But if they do become a problem, or if someone, maybe not us, but someone else raises a concern about it, it's something to pay attention to and could be a reason why you would get a neuropsychological evaluation. If someone's noticing changes in their thinking skills, if their family is noticing changes, if maybe they're not noticing a lot of change, but they would just want to see, am I having some trouble here? If I am, what kind of problems are they? And what can I do about it? A number of people who are candidates for DBS, it's often a requirement to do a neuropsychological evaluation. So if any of you have done that or may do that, that may be a component of that workup. And sometimes seeing a neuropsychologist can help to develop a plan in terms of other things for future needs. There's other people that can help with that process too. But paying particular attention to some of the cognitive changes that can take place and maybe get worse as time goes on. A neuropsychologist can play a role in helping with that planning aspect sometimes, or at least recommending certain steps or suggestions that may apply later on down the road. Okay, I think that was a lot of stuff to get through. Um, I like to end with a joke sometimes. The doctor gives the Parkinson's medication to the patient, and the instructions say shake well before use, and he gets a chuckle out of that. But as you can see, the patient was not so impressed with that joke. So thank you, everybody, for your attention. I appreciate it. With the time we have left, I'm happy to try and answer some of the questions that have come through.
Well, we did have a comment that they enjoyed your cartoons and drawings, that they really helped. So it's always
Good.
helpful to bring home a point. So thank you. You covered a lot of stuff. Like I said, we have a lot of great questions that I think we're going to probably have to bring you back for a part 2. But just, I'm going to try to highlight in just the next couple of minutes, some of the big ones. So driving is one. Like, at what point and what things should people be looking out for in terms of it maybe being an issue? And then what's the best way of managing that hot topic?
Well, so I guess I'll start by saying that the topic of driving is extra complex here because there's at least two considerations. One is the physical component. So in order to drive safely, we have to physically be able to do that, which involves everything from being able to see, being able to physically turn the wheel and step on the gas, being able to turn our head around and see behind us and so forth, all the physical aspects of driving, some of which can be a problem, especially if the physical Parkinsonian symptoms are not well controlled. And then there's the cognitive aspect of it, which, okay, let's assume someone's physically able to drive. Cognitively, can they drive? That's a different question. Driving requires a lot of things, from remembering where you are and where you're headed and how to get there, to paying attention to many things simultaneously. How far am I from that car in front of me? How fast am I going? Is there someone in my blind spot when I'm trying to change lanes? The passenger keeps talking to me and asking me questions about what I want for dinner. You know, there's a number of things going on at the same time, and that's another complication. So I think that I would encourage people to, think about driving in both of those ways. And from what I've heard, you guys may have more insight on this than I do, but sometimes people that I've seen with Parkinson's, they know when their physical symptoms are bad enough that they shouldn't drive, and so they don't during those times. But then other times they might feel safer with it. So there might be a way to gauge that, the physical part, but the cognitive part is much harder. And particularly because the person themselves may or may not be as aware of those issues. So if the person with Parkinson's or the family member has observed something that's concerning from a driving standpoint, I think it's worth mentioning to the doctor. That doesn't mean you're going to get your license taken away on the spot. But it's at least worth bringing it up so that you can have a conversation about it and try to understand why it's happening. Is there some further assessment that needs to be done to determine that? Or maybe there's just a restriction that can be put in place, something maybe like, okay, well, let's not drive at night, or let's not drive during rush hour. Let's only go drive to local familiar places and maybe not on the highway. So there may be some limitations imposed that would not require someone to stop driving completely. Obviously, that's something that some people would give up easily, but other people not.
Awesome. Well, we are past our hour time, and there's like a bunch of questions, and I even wanted to kind of tag on some of the things you said in regards to apathy and all that. So I have a feeling we're going to have to bring you back for a second half to this so that we can answer
Sure.
some of these. But I want to thank you so much for joining us today and sharing your information and your expertise. And we'll see if we can't schedule you for a part 2. For those of you who do want to know a little bit more about Lewy body dementia, we actually do have a lunch with docs tomorrow talking about the difference between Alzheimer's and Lewy body dementia. So tune in for that. Otherwise, if we could all, can you stop sharing your screen for just a minute? Dr.
Sure.
Logalbo, we like to exit so we can see everybody and give a wave goodbye. So once again, thank you so much for joining us. Thank you everyone for joining us today. And we'll see you again soon. Thank you.
Thank you.